And then when you write, do you mind to write on this side because of where your camera is so we can see it and I'll erase this?
Oh, absolutely. Right on the left.
Perfect. Thank you. Can you hear?
I can't hear any. Okay. Can you guys hear me next door? I can hear myself. That's exciting. Oh, I hear you. Okay, so we're on the PowerPoint that says ABG interpretation. Tic-tac-toe style. This is where we get to do some fun stuff. You can just look on it online, and we've got it up here. You just need to have the handout that I passed out, because we're going to do some practicing with it so that you're more comfortable with it. I believe Ms. Bailey went over some of this in fundamentals, but we're going to build on that. We're going to get into a little bit deeper understanding of what it means, what's going on in the body. First, we're going to take a step back and just talk about ABGs and how to interpret them. And then we'll jump into the other PowerPoint and we'll talk about, so what does this ABG mean is going on in the body, okay? Okay, let's get her started. I shouldn't sing for you, it might hurt your ears. Yeah, you singing it? Okay, so the first thing that you need to know, we're going to go step by step on how to do these ABG interpretations. ABG means arterial blood gas. It's a test that we take here in the artery that lets us know more about the pH. What do we know about the pH of the body?
Fluid balance, yeah.
Fluid, part of it's the fluid balance, it's an acid, the hydrogen balance. Somebody said, what was the level?
7.35.
Yep, 7.35 to 7.45. What happens to the body if we get very far outside of those limits? Check, that's right. And it can be deadly, right? We can't survive when it gets too acidic or too alkalotic, which means basic. Alkalosis or alkalotic is the same thing as a base, okay? So these ABG labs, after we draw that ABG test, you'll see these results. Also, you'll see an oxygen, but these are the ones we're going to use to interpret what's going on in our body. How is our body using oxygen? Are we acidic? Are we alkalotic or basic? 7.35 to 7.45 reflects as changes in the hydrogen ions and homeostasis, too high or too low, incompatible with life. These labs you really need to memorize. When you watch the video with Mike RN, he said, hey, write these over and over and over until they're in your head, because you'll use them over and over. You'll use them when you're interpreting, not just your quiz, but as you go through your career too. I work pulmonary MedSurg. We do ABGs all the time. If we're going to be doing a BiPAP therapy, that's a machine with a mask that helps the patient breathe in and breathe out to completely ventilate. It's a step before you have intubation, where the machine breathes for you completely. We use ABGs to evaluate when it's needed, what's going on in the body, that alkalosis, acidosis, metabolic, or respiratory, and then also to see if it's effective, right? Did we see changes from our treatment? Did it work? That's the evaluation part of our nursing process, our ADPI. So these are the numbers that you need to know. pH, that is if we're in homeostasis. pH, CO2, carbon dioxide, 35 to 45, that reflects our respiratory status, right? And then bicarb, 22 to 26. Please make note, in your book, I think they have a wider range. I think it's like 21 to 28. We're going to be using 22 to 26, okay? So make sure that these are the labs that you know, the lab values that you know. I'll remind you again as we go through class, right? These are the numbers we use on the floor. These are the numbers that I believe NCLEX is using. But variables sometimes happen with how labs are interpreted. I want us to all use the same ones so we get the same answers. Does that make sense? Yeah. So these are the lab values that we need to know. Okay. Bicarb reflects our renal status, and we're going to talk a little bit more about what that means. But these are the levels that you need to know. Know which lab represents which body system. Those labs represent something that's happening in the body. Our pH we've talked about, you know, is it acidic, is it basic, or alkalotic? pH, CO2 has to do with carbon dioxide. That's a product of our waste product when we breathe, right? So that's our lungs. And then bicarb has to do with our kidneys. Sometimes the gut and the intestines help too, but mostly the kidneys. Next, we need to know if the number, the lab value, right, the lab value from our ABG is an acid or a base. Mariana, you were talking about that a little bit ago, right? So in order to tell if it's an acid or a base, we've got to know what the values are. An acid for pH is less than 7.35. And base or an alkalosis state for pH is 7.45. Now, PaCO2, it's the black sheep of the family. It's got to be a little different, right? With pH and bicarb, the lower the number, it's acidic. The higher the number, it's basic. But with CO2, it's the opposite. It's the opposite. So that's the one that gets flipped. Exactly. CO2 gets flipped so that we have, on our chart, we'll be able to say, hey, these numbers are acidic and these numbers are basic or alkalotic. So acidic state with PaCO2, that's our carbon dioxide, is greater than 45, and the basic state or the alkalotic state is less than 35. This is the one that's opposite of the other values. So when we go to write down our values, we're going to go ahead and flip it. See what I've done here? All of these numbers are acidic and all of these numbers are basic or alkalotic. I flipped the CO2. Well, I will. I see why your face. Here, I switched them. Okay.
This might sound dumb. So then should we just memorize that PaCO2 is 45 to 35? Because originally it was just written as 35 to 35.
You sure could. That'd be one less step for you to take. If that works, that's how your mind works, and it makes sense to you, yeah. Absolutely. Because I do want you to flip that. That's going to make tic-tac-toe lots easier to play. So this is how you write your labs to play tic-tac-toe. And then this is what the tic-tac-toe looks like. So when you go to write it on your paper for your quiz or you're interpreting labs at clinicals or when you're a nurse, you can just write a little tic-tac-toe board and write your labs on the side. This is already fancy for you. It has the nice outline. Just a reminder of what's going on with these labs and what it means. The pH determines whether it's acidotic or alkalotic. How do we tell if a patient is acidic or alkalotic? What lab tells us? pH. The pH. That's going to tell us if it's acidic or alkalotic. Okay? And then to decide if it's respiratory or metabolic, what lab tells us if it's a respiratory issue? Yeah, the one that has oxygen in it. I like that. The CO2, that's the waste product of when we breathe. And then metabolic, bicarb, that's the HCO3. Okay? And then whichever one's abnormal will be whether you can tell if it's respiratory. If the CO2 number is messed up, it's a respiratory issue. If the bicarb is messed up, it's a metabolic issue.
So what's the lab?
Bicarb, HCO3. HCO3 is the chemical formula for bicarb. Yeah. Yep. That's what you'll see in the lab values. Oh. Good question. Okay, so now we're going to do an example of how to do this. This is a lot like what you did with Miss Bailey last semester. we go ahead and write our numbers at the top and we flip it, just like you were talking about, 45 to 35, so that we have our acidic on one side and our alkalotic on another. And then this is our example question. 2 in a column means a tic-tac-toe. How do we get a tic-tac-toe? 2 in a column, right? And that's going to tell us if it is acidic or alkalotic, and then what system is out of whack. What system is abnormal, okay? And by being able to interpret those values, we can then tell what's going on in the body. So let's just start at the very beginning. pH measures, yeah, acidic or alkalotic, right? That's our homeostasis. We can't live if we're too much one way or the other. So 7.52, when we plug that into acidosis, normal, or alkalosis? Alkalosis. Alkalosis, right? Okay, next value, PaCO2. What's that reflect? The lungs. CO2 is the lungs. That's respiratory, right? The value is 28. 28. Yeah. And then bicarb's 22. Oh, you're jumping ahead. So now we've got our labs plugged in, and we can start to interpret what's going on. Okay, so. Ooh, look at you. Look, you are jumping ahead. Hold on, Nellie. Your friend's got to catch up a little bit, okay? So we see this here. Is this what you got? Bicarb, normal, PaCO2 alkalotic, pH alkalotic. Where is our tic-tac-toe? Right here, yeah. So we know that the problem is our body is alkalotic, and which system is messed up? Right, so we have respiratory alkalosis, right? Next, let's talk a little bit about compensated versus uncompensated. I heard someone in the back already talking about that. We've started with the basic question, what's going on in the body? And now we're going to talk about what's the body doing about it. We know that the body has lots of different things, feedback loops, that it does to try to maintain homeostasis, right? Balance. It takes teamwork to maintain that, right? When the kidneys aren't working just right, the lungs kick in and try to help, and vice versa. When one system's helping the other, it's called compensated. That means they're trying to help. Then later, we'll talk about, is it fully compensated or partially compensated, right? Was it effective or not effective? Right now, we're just looking to see if the body's trying to help. When one system's not helping the other, it's called uncompensated. When the system's trying to help, it is compensated. And we'll see that by abnormal lab values. Watch and see. Okay, looking at the results of these lab values that we just had, right? We had our tic-tac-toe. We know we have respiratory what? Alkalosis. Now we have to decide if it's compensated or uncompensated, right? So, is bicarb helping? No, because it's in the normal range, right? If it was helping, it would be abnormal trying to balance out alkalotic state, right? Well, it's the opposite. It needs to be outside of it to pull it the other way. It's like to balance those plus and minuses, yep. So we know it's uncompensated because it's not helping. It's not helping. Let's look at another one and practice it. This one I want you to do on your paper. I want you to try it on your own, and then we'll walk through the answer, okay? Have your lab values at the top, and we switch the PaCO2 because it's the opposite. This is our question down here. Tells us the lab values that we're interpreting. And then we use our tic-tac-toe. Give it a shot. See how it goes. Let's see what you got. Okay, did you get this? Where does the pH go? Right? Because we look at our levels and we know it's in the acid level. It's not normal. And then what about our PaCO2, which reflects what status? Respiratory, our lungs, right? It's 55. So it's, yeah, because we flip our PaCO2, right? It's also in the acidotic state, and that makes a tic-tac-toe, because 2 in a column makes tic-tac-toe, right? And then our bicarb is a 29. Where does that put it? Alkalosis. So is the bicarb helping? It is. So we know that we have respiratory acidosis. The pH tells us if it's acidotic or if it's alkalotic. The fact that this is, we got to have 2 to match. That's how we know it's respiratory, right? And then bicarb's outside of normal too, so we know it's trying to help. So that's compensated respiratory acidosis. Yes, not there yet. You're so good, but yes. This is a tic-tac-toe trick. Even if you don't remember it, you can still just do these steps and get the right answer. But if you have the middle section, nothing is normal, you know that it's compensated because there's a helper. Both sides are outside of the normal range trying to balance the body out, okay? And then how do we tell, Casey's already jumped ahead a little bit, how do we tell if it's fully compensated or partially compensated? That means, did the helper work? Did the helper help us gain balance? The pH will tell us exactly, because that represents whether we're acidic or basic or normal. That normal is our homeostasis, right? So this one's easy. You've determined the ABGs are compensating. We know that there's a helper. They're trying to get the body back in balance. Now you have to figure out how much. Is it fully compensated or partially compensated? Partially means that the pH is still abnormal. Probably better than it would have been if we didn't have both the bicarb and the PaCO2 working together to try to balance it. Fully compensated means that the pH is normal. So if the pH is normal and our bicarb and our PaCO2 are abnormal, that's an example of fully. Yes, ma'am?
How do you know it's symbolic if the pH is normal?
You are jumping ahead. I like how you're thinking. Let's go on. Practice time. I bet we do a question just like what you said. The question was, how do we tell if it's respiratory or if it's metabolic? And then how do we tell if it's acidotic or alkalotic when it's fully compensated? Good question. These are some practice problems. We're just going to work a couple of them. There's also a video on your Moodle where it's called a guided tutorial. So if you're like, we get done with lecture and you're like, I could use some practice on that, it goes through it. It gives you examples. You can pause it, work through it, and then unpause it, and it'll show you how to get the answer so you can check your work. Does that make sense? That just kind of helps you see the process if you need a little bit more after today. Okay, questions 1 and 2 is what we're going to do. We write in the top corner, we write our lab values with our PaCO2 flipped. So everything on the left is what? Acidic. Yeah, acidic or acidotic. And everything on the right is, yeah, alkalosis, alkalytic, same thing as base. The first lab value, 7.23. Where does that put the pH? Acidosis. What about PaCO2? It's 37. Yep, on the base side. And then bicarb is 18. So this makes our tic-tac-toe, right? Because 2 in a column gives us a tic-tac-toe. So what would we call that? Metabolic. This tells us it's metabolic, and this tells us acidosis.
Maybe I'm not catching on, but wouldn't the CO2 be normal?
I put it in normal too, especially because there is 37 between.
Oh,
Yeah, and 37.
Or am I not thinking of it right?
no, you are. You are. What a good catch.
I didn't say anything.
I love it. I'm so sorry, but what a great catch. That means that you're clicking along. I'm sorry next door if that caught you off guard, but what a wonderful catch. So what she was saying is, hey, your level's off on your chart. Your tic-tac-toe's not right. That PaCO2 really needs to be in the normal range because it's 37.
So it's not concentrated. It's still partial, I guess.
It's uncompensated now because PaCO2 is no longer helping. If it's staying in the normal, it's being a lazy teenager. I'm sorry, I'm referring back to my teens at home. They're not helping pick up the house. They're not helping try to balance out the body or the homeostasis. So we would change this to metabolic acidosis uncompensated. And when we go to uncompensated, we don't have to talk about partially or fully. We just say uncompensated. What a great catch. Let's see if I made any more mistakes as we go on. This is the one that you were talking about. Straight across indicates fully compensated. That's one of those tic-tac-toe tricks. When we said if the middle is empty, that's an indicator that it is compensated to some level. This is another tic-tac-toe trick. If the values are all across the top, we can automatically know that it's fully compensated. Let's talk about why and how to interpret it if it's fully compensated. That's probably the most difficult type of question, but we can do it. Our lab value 7.45. Make sure I'm right here. Where does it go? Normal. Our PaCO2, which is our lungs, our respiratory, it's 20. Here. Bicarb's 20. Where does it go? Okay, so we did have that one right. That's good. Great, so we know it's fully compensated because both sides are outside of normal limits, the lungs and the kidneys, or the metabolic and the respiratory, but the pH is normal. So what they're doing to balance is working. The body is somewhere within the normal range. Usually the body's not 100% in the middle, so we can tell if it's acidic or alkalotic based on how close it is to that side. Let me explain. So our pH is 7.45. Which side is that closest to? Alkalosis. So that's how we tell that this body is alkalotic or alkalosis. And then when we go to look at the respiratory level, it's a 20. How far from normal is that? How many units? 15, right? 20 to 35 would be in the normal, the closest normal limit. So 15, and bicarb is a 20. How far from normal is 20 on bicarb? 2. So which one is more irregular or abnormal? The respiratory. So that's how we decide what's going on in the body if we've got a compensated lab value or a lab set. Because the respiratory lab was the most abnormal, that's how we know that the respiratory is the one that is controlling this. And then because the values were more alkalotic than acidic, that's how we know that it was alkalotic. That is the pH. That's the hardest one to get. You won't see those very often, but how you tell us how far from normal is it? The one that is the farthest from normal is the one that's the controlling factor.
If it's normal, why is it? We're just saying what it's closest to.
Because we know that it's a good question. we know that both the kidneys and the lungs are not normal. The only thing normal is the pH, right? So something's going on in the body, and we can tell that the lungs and the kidneys, the respiratory and the metabolic, they're making changes to balance the body. If it was totally normal, they would all be a normals. But these are
Okay,
abnormal.
on this thing before this, there are 1 and 2 of ABGs on there, and they aren't lining up with these 1 and 2 that you're on right now. Do you mind to go back and do those 2 and then?
So like the practice problems on the cycle.
Yes.
Your pH for the how much members use on practice problems is different. There.
Okay.
Here's a 7.5 to 7.56.
Let's go back.
It pulls more.
7.56.
Right, but the range of it to be, so.
This 2. We'll do this by hand.
Pulls more.
What are my lab values? Help me out. What's my pH normal? What's my pH normals? You guys next door can talk too.
7.35 to 7.45.
Got it. What about our respiratory? What's our normals? We flip this one.
45 to 35. Oh, I should do it.
45 to 35. Okay. And then what about our bicarb?
22 to 26.
So this side is acidic, and this side is base, right? We're going to draw our tic-tac-toe. I'm an excellent drawer. Now, what's our pH? Which side does it go? Because it's on this side, right? All right, PaCO2 is 20. Where does it go? pH, 2, 20. All right, and then what's our other lab value? Our bicarb. It's a 20. Where does it go? Do we have a tic-tac-toe here? Great. What does that say? How do we interpret that? This makes it respiratory, and this makes it alkalosis. Okay, so now we've got to decide, is it compensated or uncompensated? How did you know that? That's right, it is compensated. How did you know that?
Because it's over there.
Because we've got an abnormal value, we've got a helper. Right? Now, is it partially or fully compensated? Okay, it's partially. How did you know that? Because the pH isn't normal, right? In order to be fully compensated, our changes have to make our pH normal. Let's do another one. Yeah, it's just for your help. If you don't need that, that's fine. Are you with me next door?
We good? Do you want her to do some more?
Let's do number 6, okay? Take a minute and do number 6 on your paper.
Kind of a random question. Is there a way that your pH can be out of that uncorrelated
It's one of the main buffers. We'll get into that in the next part. That's a good question. Okay. So, critical thinking. You're like, okay, how does this apply? I like that. All right, let's start with our pH. Where would the pH go and why? Alkalosis, 7.55 pH, because it's above the normal range, 7.45. Now our PaCO2 is 47. Where does that go? This side, right? Because it's this way. What was our value? 47? Yeah. Okay, last piece is the bicarb. It's 30. Where does it go? Do we have a tic-tac-toe? Here? What does that mean? How would we describe this or interpret these ABGs? We know it's metabolic because it's the bicarb system that's out, right, that matches. So metabolic what? Next step is decide, I know people are jumping ahead. The next step is decide, is it compensated or uncompensated? What do you think? So we know to some degree it's compensated, right? How do we know that? Yeah, we have a helper, right? If this had been normal, it would be uncompensated because they're not helping. Now we have to decide, is it fully compensated or partially compensated? Which one did you pick? Partially. Why did you say partial? Yeah, this is how we tell if it's full or partial. Just the pH level. If the pH was normal, then it would be full. If it's abnormal, it's partial.
Because acid is more invasive than alkaline.
Well, because if the helpers, these two, are effective in balancing, it will be in the normal range.
So if you have your CO2 on one side and CO3 on the other side, it's automatically compensated.
Depends on where the pH is. But yeah, if the pH is in the middle. Oh, no, I see what you're saying. Yes. Let's do 5. Let's do number 5. Are you with me next door?
Yes. Will you let us answer before they answer?
Yes. Here we go. Let's draw our tic-tac-toe, guys. What's the label here on this side?
Acid.
What's in the middle?
Normal.
And on the right?
Alkalosis.
Great. The first part of the problem is the pH. Where does that go if it's 7.46?
Alkalosis.
Great. Now the PaCO2 is 36. Where does that go?
Normal.
Very good. And the bicarb is 32. Where does it go?
Alkalosis.
That's right. Do we have a tic-tac-toe?
Yes.
Here?
Do we?
Yes. What would you describe that as? How would you interpret those values?
Uncompensated.
Okay.
Metabolic alkalosis.
This makes it metabolic, and this makes it alkalosis. Yes. And how did you know that it was uncompensated? Because that is correct.
The CO2 is in normal range.
Right, so it's not helping. So if it's not helping, it's uncompensated. You guys did great. Does that make more sense now?
We have a few head nods.
Do we need to do another one, or are we ready to move on? Let's do one more. Also, guys, remember on your Moodle, there's a guided tutorial. So if you get done with today, you're like, I still got a few places that I get lost, go do that. Yes, ma'am.
So, that's one of Kevin's emails, if there's no fully or partially uncompensated, it's just uncompensated.
Well, so that's a good question. What Kayla asked was, well, it's uncompensated. Don't we need to decide if it's fully or partially? If it's uncompensated, it's not full or partial. The only time we talk in terms of full or partial is when it's compensated. If they're not helping, then it's just uncompensated. That's a good point. Let's do number 4. I'm going to let the class next door help me again, okay? Let's draw our tic-tac-toe. Where would I put the pH?
Alkalosis.
Alkalosis.
Okay. Where would I put the CO2?
Alkalosis.
Alkalosis.
Where would I put the bicarb?
Normal.
Normal.
Do I have a tic-tac-toe?
Yes.
Yes.
What does my tic-tac-toe say?
Uncompensated.
Is it respiratory or metabolic?
Respiratory.
Respiratory, alkalosis, and you said it's uncompensated. Let's go over how you found that, because that's right. We know, how do we know that it's a respiratory issue?
The CO2.
The CO2 is abnormal? Yep. How did we know that it was alkalosis?
Because what? The pH.
That's right. Good. And how did you know it was uncompensated?
The bicarb is normal.
The bicarb is normal.
It's normal. It's not helping. It's not helping. Good. Good. So those are the basics of ABG labs and interpreting what's going on in the body as far as if it is alkalotic or acidic, if it's respiratory or if it's renal. And now we're going to take a quick break, 5 minutes, let your brain rest for a second, and then we're going to come back and we're going to talk a little bit about what's going on in the body and what can cause it to be alkalotic, acidotic, respiratory problems, renal problems, okay? So it is 9:25. Let's be back at 9:31. Deal?
The CO2, 45 to 35 is already flipped, right?
Yep, I wrote it flipped up here.
And it's bigger and smaller.
I know, but we're just like, because I tried not to write it down on the, I just go off of, but I keep wanting to make it the same
I think
way as the other one.
like 35 to 45.
Yeah.
That's the biggest thing. But you'll have your PowerPoint to kind of go back to as far as like, okay, the steps. That helps. And it's kind of fun.
Yeah.
Once you get the hang of it, you're like,
These on tests or anything?
there's going to be tests. Yeah, we're going to have a quiz next week, and there'll definitely be some of them. It'll be good.
Another freak out moment for me, thanks.
Oh, you're going to do great.
Will we get a longer break later?
We'll have a 10-minute break. What time do you have to go to the thing?
Between 9 and 11, they said. I wear up there.
They're gonna do you today, but they told me they wouldn't give me until tomorrow or on Monday.
I told them, I said, I absolutely cannot do it Monday. I said, I work Monday. They said I could come in today. Between 9 and 11.
Soft because that one I'm supposed to do on
I don't want to mix
the bigger one.
Yeah.
All right, guys, we're going to take a look at the PowerPoint here, Chapter 12, Acid-Base Balance. So now we've went over what ABGs are, and excuse me. Now we're going to talk about what's going on in the body that causes it to be acidic or alkali? What signs and symptoms? This is that assessment component. And a lot of MedSurg 1 is about the assessment, right? What do we see in our patient? What do we hear? What do we feel? What are the labs? What are the indicators that something's off or wrong? So a lot of it is learning what's normal so that when we can see that it's abnormal, we know there's a problem, okay? These are some key terms. I just put this at the front to sort of let you know that if you know these terms, you don't know everything, but you'll be more comfortable with this material. You know, if you talk about metabolic acidosis, those are all terms that are going to be used as we discuss what's going on in the body. And so being familiar with them will help you understand the content of acid-base balance.
I don't understand.
It's just a list of terms.
But why are things that are pH and acidosis? Those are just.
It's just a list of terms.
Yeah, it's
Oh, maybe it's the way I'm looking at it.
It's just a list of terms. Yeah, I don't mean to be complicated. It's just these terms will help you have a better understanding of the unit. All right, let's talk a little bit about acid-base balance. I think I should stand over here for that. Acid-base balance in the body is used to maintain homeostasis. We were talking about that, right? That's the balance of the body. It's a very narrow window. If we get too far outside of it, one way or the other, it's not compatible with life. We have buffer systems in our bodies, which are chemical formulas, chemical balances that are acid or a base. We've been talking a lot about acid and base to try to maintain that homeostasis, that balance in the body. So then in practice, that buffer solution, that's got a little bit of base or a little bit of acid to help balance it out. When we talk about acid base and homeostasis, homeostasis is maintained by the level of hydrogen ions. Now, you can go back to your chemistry class when we can talk about formulas, but I want you to understand that hydrogen ions gain or loss has an impact on our acid base, has an impact on our pH. Okay? And its pH is an indirect measure of those free hydrogens, right? And this is a point to remember as well. A change of 1 in pH. So let's say we went from 7.45 to 7.5 is a significant change. So even though that 0.1 change looks small, it's a big change in the body. A lot's going on with the chemical buffers in the body. The pH is a representation of the body working between the lungs and the kidneys. Normal blood pH, this is the levels that we were talking about, right? And ABG stands for arterial blood gas. So it's a blood sample that's taken from an artery. Sometimes they miss and get a venous blood, and then our lab values change. But when we do our interpretations, like our tic-tac-toe, we're really talking about arterial blood. This is the level that we are using. Okay. Introduction to acid base, just the chemistry behind what's going on in the body. Acids raises acid by having more hydrogen ions. Bases, we're going to reduce hydrogen ions. Buffers are those things that try to balance things out. Bicarb, what regulates our bicarb? What part of the body? Bicarb. Kidneys, yeah. Kidneys are one of the main pieces. Yes, Kayla.
What causes such a different range from the arterial and venous? Like, I mean, why is the venous lower?
So let's think about arteries. What kind of blood are arteries carrying? Oxygenated blood from the heart, right? What kind of blood is venous carrying? It's the used blood, right? So when we get the blood fresh from the heart from the artery, then we know this is the best it is. That's the difference. The venous is the used blood coming back to get refilled, if you will.
The venous blood is carbon dioxide.
Yeah, it's used. Arterial is the one we use, the ABG, that A and arterial, A and A.
Thank you.
Yes. Okay. Talked a little bit about the acid source, and these are some of the places that we can get acidic from. Breakdown of glucose, so we'll see some acid imbalances or some imbalances with folks who have diabetes that is out of control, so like DKA. We'll talk about when there's destruction of cells and how that changes the acid-base balance in the body. We talked about bicarbs comes from the kidney and sometimes also just the intestine in general. We'll talk a little more about that. If you watched your video that I asked you to watch before class, he kind of talked about that, didn't he? That's the helper. That's one of the helpers for the kidneys. 3 compensation mechanisms that we've been talking about. The chemical buffers, just the blood changes. But really what we focus on are respiratory and renal. And we need to know which one works faster and which one works better, right? So respiratory is the retention or elimination of CO2. CO2 is the waste product from our breathing, right? This happens within minutes. When we breathe faster, it has one effect on our body. When we breathe slower, it has another effect on our body. And that changes our acid-base balance. But respiratory compensations can lead to mild to moderate shifts. So it's not super powerful, but it happens fast, right? Now, renal, the kidneys, it's more powerful, but it can take hours to days to work, right? So we'll see respiratory changes before we will see kidney changes. Does that make sense? This works faster, this is stronger, but takes longer to work. I'm just going to check my notes and make sure I'm not forgetting anything. Do know your critical ranges. If your pH drops to 6.9, you'll be in a coma. Okay? At 6.8, you're likely going to die. So that's not a big window, is it? A little bit of change goes a long way.
Hey, real quick, renal, you said respiratory works faster, but renal.
It's stronger, has a stronger effect. The question was, respiratory works faster, renal has a stronger effect, but takes longer. Okay. This is from the video you watched with Mike the RN, and it just talks a little bit about memory tricks. How do we remember? And I think you guys have this, but basically it says carbon diacid. The acid is more we have of that, the more acidic we are, right? If we're retaining CO2, we're likely to be acidic, right? Because it's an acid. And vice versa, base is a B with bicarb or bicarbonate. So we're likely to be alkalotic if we're retaining our base, right? What could also make us have too much base or throw us in balance? Oh, okay, yeah. If we're losing acid, then it seems like we've got more base because we've lost our acid, right? So that can put us out of balance on that teeter-totter, right? So true, if we're losing acid and keeping base, it'll still put us in an alkalotic state. Good. Another main player in acid-base, we talked about those hydrogen ions, that's the pH balance, right? Think H for hydrogen ions and high acid. Some of the places that you find that is your stomach acid and your urine. Right? That's part of what the kidneys are doing, regulating with your acid-base balance.
The kidneys are taking up the hydrogen ion.
They can, or they can excrete more, depending on what's needed. They can do both. Acid-base imbalances and ABGs are all about hydrogen acid can make things acidic. It's an acid. Carbon dioxide is an acid. Bicarb is a base. That's just a summary of what we just went over. I want to go back for a second. Let's talk a little bit about what this means, right? We talked about the double Bs. If we have too much bicarb, what condition do we get thrown into? Acidosis or alkalosis? Alkalosis. If we have too much carbon dioxide, are we acidotic or alkalotic? Acidotic. Very good. If we have too many hydrogen ions, are we acidotic or alkalotic? Acidotic, because it's an acid. Good. Good, you got this. All right, let's talk about the respiratory compensation mechanism. How our body tries to balance things out by changing our respiratory pattern. We know when we do a respiratory assessment, one of the things we look into is the respiratory rate. Hey guys, how many times, you may not work in the medical field, so you may not know, but actually count respirations. Sometimes that's one of the values that people just say, oh, they're 16, they're 18. You want to actually count, because a high level can mean something different than a low level. But anything outside of the norm indicates that your body's trying to compensate for something going on inside. Those signs and symptoms help paint a picture of what's going on in our body so that we know what interventions we need to do to best care for our patient. When chemical buffers alone can't prevent the blood pH changes, we're out of balance and the blood can't handle it by itself, the first place we see changes is the respiratory system, the respiration rate, and how we're breathing. We can have shallow breathing. We can have deep breathing. We can have fast and slow breathing. You don't want me to do that, I might pass out. So then that we describe in terms of hyperventilation, meaning very quick breathing, right? Fast respiratory rate. And hypoventilation, that's the slow. Hypo, slow, low, all those go together. Yeah, you're not blowing off the CO2, right? You're not blowing it off. That's good, yeah. Hyperventilate, you breathe too fast and you're blowing it off. You're blowing off the acid, so you become alkalotic, right? You blow off the acid because you're breathing so fast. You're panting. And then like hyperventilation. And then hypoventilation, you're retaining the CO2. Is CO2 an acid or a base? Next door, tell me. Is CO2 an acid or a base?
Acid.
Great. And since we're holding on to CO2, what happens to our balance? Are we acidic or alkalotic?
Acidic.
Excellent. Good. So if you breathe too slow, like maybe you just came out of surgery and they gave you a whole bunch of medication and you're not taking deep breaths and it's slowed respiration rate, then you retain the acid and you become acidic. Good. Good, 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 good. All right, let's talk about the kidneys. So the lungs make quick changes and we see effects quickly, but the kidneys take a little bit longer, hours versus minutes, up to days, but hours versus minutes, and it's more powerful shift, right? This is the third line of defense for pH changes. It can take longer, up to 24, 48 hours, and it controls the hydrogen ions and the bicarb, right? So we can see changes there. We can, with our urine, it can change if it holds on to the acid or excretes more acid, and the same with the bicarb. Kidneys can correct and compensate for pH changes when respiratory system is overwhelmed. When it's being a helper, the first go-to is your respiratory system, and if that's not enough to compensate, then the bicarb or the renal comes in to help, okay? What is that? I don't think so.
Like, I didn't mean your phone, I meant like you on the computer.
Oh, I think it was next door to me. Okay, let's talk about kidneys. Kidneys have a friend in the intestines, right? And here's what's going on. Hydrogen ions are the acid that it controls, bicarbonate's the base that it controls. We can have that either absorbed more if we need more of one, or excreted more if we need less of one. And then we have bicarb in the intestines as well. So if we have a whole bunch of base, which is bicarb, right? Let's say we get diarrhea. So our intestines is all about base, right? We're excreting what? What are we getting rid of out of the body? What are we getting rid of?
Oh, base.
Yeah, base, but, excuse my language, base, but we're getting rid of the bicarb.
So you're gonna be more acidic.
So all that's left is the acid, right? Base, bicarb, but getting rid of that leaves the acid. So if you're losing it out of your arse, then you are acidosis.
The video.
The video is pretty fun if you haven't watched it. Let's do a scenario. Let's apply some of this information that we've been talking about, okay? That way it gets stuck in your head better. Here's a scenario. A patient comes into the hospital ED with diarrhea for the last 4 days. What acid-base imbalance is he at risk for? Don't say it here, I'm going next door. What acid-base imbalance is he at risk for if he's had diarrhea for 4 days?
Metabolic.
Acidosis.
Acidosis.
Check, you are on point. Yes. Good, 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 good. Compensation, we've kind of already talked about this. Too low, you're gonna die. Too high, you're gonna die. That's why it's really important to watch for signs and symptoms that show that you have an acid-base imbalance. It's a real narrow window. If your patient is breathing 40 times a minute, they can't hold on too long at that rate. They're gonna get tired, right? They're trying to compensate. They're trying to get their body balanced. But at some point, they're gonna run out of energy to breathe like that. We talked about respiratory's first, but kidneys are more powerful. And we talked about fully compensated and partially compensated when we did our ABG interpretation. These are just those terms that we've been talking about: metabolic acidosis, respiratory acidosis, metabolic alkalosis, respiratory alkalosis. And this is just a little chart of what's going on in the body. When we're in respiratory acidosis, our pH is low, our CO2 is high, and our bicarb could be normal. It's just a general summary chart. If you know how to do tic-tac-toe, when you get those lab values, you can figure out, is this alkalosis? Is this acidosis? Is it metabolic? Is it respiratory? If you know how to do the tic-tac-toe, you don't have to memorize that chart. You just use that process. It's really handy. You have a lot of other things that you have to memorize. So being able to do that tic-tac-toe is very helpful. Again, this is just another chart of information. We talked about pH being the measure of acidity or alkalinity based on the hydrogen balance. And we know that 7.35 to 7.45, we get too far out of that, it's not compatible with human life. It's a very small window. PaO2 is a different lab that we haven't talked about. The O2 stands for oxygen, right? So that's just a measure of how much oxygen is in your blood. So your pulse ox might be one thing, but when I check your arterial blood, that's a more accurate representation of how your body is using oxygen. So it is a better indicator of your respiratory status. And you want it to be between 80 and 100. CO2, 35 to 45. That's the carbon dioxide. That's the waste product from breathing. And then the bicarb with the kidneys and intestines.
Well, I have a super good question. We go back.
You don't know.
When it says 35 to 45, and then it's mercury, that's per breath.
It's not about breath. That's your blood level. That's your artery blood level.
Pressure per pump, like per.
Do you want to know what the MMHG is?
It's just like a blood test. So it's the overall value, the like percentage in the blood of how much it is. Oh, percentage. That's a good question.
Saturated.
The PaO2?
Isn't 80 pretty low?
So that's not the same as the pulse ox. So our normal lab would be 80 to 100. That's a good question. That's you thinking and applying. I like those sorts of questions. When we have a pulse ox on a patient, if you're in clinicals and your patient's at 80, that's a problem. Anything below 90 is outside of normal limits when it's a pulse ox test. But this is normal for an ABG or a PaO2. So that's good. It's not quite the same evaluation. Okay, it's got a different scale. Good question. Good question. Categories to know. You probably already got this information. It's just presenting it in another way. Sometimes seeing it with different colors or in different combinations help you piece it together. Just one more way. If it's not in your brain yet, where to put it. All right. Now, let's talk about what's happening in the body that makes you in metabolic acidosis versus metabolic alkalosis. So we're going to focus on the metabolic side, both when it's acidic and when it's basic, right? So what system controls metabolic? The kidneys and the intestines, gut health, right? Good. All right, friend. Come on down. Metabolic acidosis. What's going on in the body when we have metabolic acidosis? We got rid of some bicarb and we're more acidic, or we're producing more acid and so we're acidic, right? And there's different things that can happen to cause that. So excessive breakdown of fatty acids. This is where we can start to have some stuff with like diabetes, under elimination through the kidneys or the lungs. Something's going on in the body that we're retaining an acid, or we can have underproduction of bicarb. If we have some, so we talked about the kidneys already, but did you know that the pancreas also produces bicarb? One of the conditions we see in MedSurg a lot of times is pancreatitis. That's where there's inflammation in the pancreas. And if it's inflamed, it's not working as well. So when we have pancreatitis and our pancreas is inflamed, we're not producing as much bicarb. If we're not producing as much bicarb, what state does our body go into? Yeah, so that could be one of the imbalances that are happening. We almost always talk about bicarb in terms of kidneys, but the pancreas has a role too. And then we talked about the diarrhea, right? If it's coming out of your arse, then it's leaving you in acidosis, right? Because the butt's bicarb. Yeah.
So like if you lose a kidney that says that you can function off of that, like most people can, but like how does your body compensate for that? Is it work harder and basically your lifestyle is just?
Yeah, so we had a really good question. It says, some people just have one kidney, and if the kidneys are so important for acid-base balance, then what happens to that kidney? So it is more susceptible to change, right? A little bit of change makes a bigger difference in the pH because it's harder for one kidney to regulate. So it'll be more important for diet, especially, to make sure, and medications and different things that can change your bicarb balance, that they're watching for that. It's a really good question. It can balance, but it's more susceptible to illness.
Is there some supplementation for like your lifespan?
Yes, you might be on some medication for it as well. Let's get into that. That's good.
Different baseline than like the rest of us.
Normal's still going to be normal for them. They might chronically run high or low a little bit.
I know they probably have it in the
Well, so they can be in chronic conditions. They can be a little bit lower, a little bit high, and their body gets used to that. It doesn't mean that it's normal, but just like with our COPD patients, you know, 100% oxygenation is great for us. But someone who has COPD, if they were at 100%, it would knock out their respiratory drive because their body's not used to running that high. So our COPD patients might be used to running 88 to 92 in the later stages of COPD. I realize I'm jumping ahead. That's just extra information, but it's applicable. Okay, this bicarb level we talked about, right? So in the book it says like 21 to 28, but what numbers are we using? 22 to 26, that's the same with Mike RN online with the video. That's what we use for our tutorial, etc. I want you to be able to know common causes, assessments, and treatment for metabolic acidosis. And we're going to have a chart and a slide on it too. But as we go through all of this, I want you to be thinking, okay, what are the signs and symptoms? What do we do about it? You know, how does it display or present in our patient? Another thing to know is if the kidney's involved with metabolic acidosis, you're likely to have some sort of imbalance with your potassium too. And we talked about potassium last week. It's a very critical electrolyte, right? It affects our heart rhythm and rate. So when we get outside of it, we have abnormal rhythm, and that can cause a cardiac event, cause death. Signs and symptoms of metabolic acidosis. I like pictures, so I've got some pictures on here. Headache, these are some of the signs and symptoms your patient might have. Decreased blood pressure, hyperkalemia. We were just talking about how the kidneys can mess up when your kidneys are messed up. You have too high potassium, too low. In this case, it's too high. Since potassium's involved, muscle contraction is involved, and that causes the muscle twitching. That warm, flushed skin, nausea, vomiting, diarrhea. Changes in your LOC, that just means some confusion. Anytime you get too imbalanced, it can cause some confusion. And then there's this term, Kussmaul respiration. Say that with me. Kussmaul respirations. Oh, someone's painting a picture here of these great big waves. What do Kussmaul respirations, how do you describe those? Deep, fast breathing. Right? Because we're trying to blow off that excess CO2. So we're really reaching down deep to try to blow it off. And we've got so much of it that we're really digging deep and blowing fast. Okay? And we need to know that those Kussmaul respirations are associated with metabolic acidosis. There's a link in your PowerPoint too that has a video of someone breathing in those Kussmaul respirations, that fast, rapid breathing. And you'll see them using their accessory muscles to really get deep breaths. Okay, good. This is just a summary chart. We got some of the pictures from our video from Mike RN. Causes of metabolic acidosis. We know that diarrhea, if you're losing it from your arse, you're in acidosis. DKA, that is some of the nutrition issues related to diabetes, type 1 in this case. Lactic acidosis from heavy exercise. Seizure, hypoxia. Hypoxia means you're not getting enough oxygen. Excessive intake of acids like alcohol. So sometimes people who have been on a binge or are chronic alcoholics are in a state of metabolic acidosis. Overuse of aspirin can also have an effect. Inadequate production of bicarb, which happens with kidney failure, and that pancreatitis that we really talked about. Pancreatitis means inflammation of the pancreas, so it's not able to produce bicarb, so your body doesn't have as much as it needs to be in balance. Talked about that. So this shows up, the manifestations are our signs and symptoms, right? This shows up with heart irregularities, dysrhythmias. We're going to be bradycardic, hypotensive. We've got that fast breathing. That's the Kussmaul breathing, right? Headache, confusion, and our skin is warm, dry, and pink. And that's important because we're breathing fast, we're working hard, so that's why our skin is warm, dry, and pink. Okay. Scenario, let's apply this stuff. You ready? A patient comes into the ED. It's very similar. This is his friend. The patient comes into the ED with diarrhea for the last 8 days. What type of respiratory symptoms do you expect this patient to have? Respiratory, that's how we breathe, right? So what's his breathing gonna look like? So we know, let's break this question down. We know that he's had diarrhea, so he's lost all of his bicarb from his butt, so he's left in acidosis, right? So we know that he's in metabolic acidosis from all that diarrhea. So what kind of breathing pattern is associated with metabolic acidosis? Deep and fast, and that's called what? Kussmaul, that's right, that's right. What kind of vitals do we expect? These are our assessment data. What kind of vitals? We're gonna see some hypotension, the blood pressure is gonna start dropping, and the bradycardia means low heart rate. So bradycardia is below 60, tachycardia is above 100. Yeah. Good. All right, let's talk about metabolic alkalosis. All right, next door, you're on the spot. Metabolic alkalosis means what's going on in the body.
The kidneys are too basic.
Yeah, so you've got a whole lot of bicarb or not enough acid, right? So your imbalance is that you're bicarb heavy. Good. Some of the ways that we can get an acid deficit, if we've lost our acid and that leaves too much bicarb, is through prolonged vomiting. That makes me think of like our chemo patients that have a lot of vomiting. Some of viral components have a lot of vomiting. GI issues. There can be a number of conditions that can cause vomiting, but prolonged vomiting causes that acid-base imbalance. Another one to really know are thiazide diuretics can really throw you into alkalosis, metabolic alkalosis. A lot of patients, whether they're heart failure usually, are on a diuretic. The thiazide's a type of diuretic. It's not pharm, I'm not quizzing you on the pills, but you do need to know that a thiazide diuretic can cause your body to excrete too much acid and leave too much base. And that can throw you into metabolic alkalosis, right? And prolonged NG suction. Because you've got acid in your tummy, did you know that the acid in your stomach is stronger than battery acid from your car? And if we're sucking all that out, we're taking all the acid out, right? So that leaves you with too much bicarb base. Yeah.
What about bulimics? Wouldn't that be about the same if you're vomiting up all your acid?
Yep. Because that's that prolonged vomiting. That's true. Hallmark of base excess acidosis, ABG results with high pH, bicarbs high as well. We know that from when we did our interpretations. Hey, it's another picture. I can't imagine that I would include a picture. Symptoms, signs and symptoms, how it presents for metabolic alkalosis. There's this really big arrow here. I think that's important. Causes of metabolic alkalosis. Severe vomiting. We talked about different things that could cause that. Excessive GI suctioning because we're removing the acid from the stomach. Diuretics, particularly thiazide diuretics, right? Because we're excreting more acid in our urine, leaving behind the base in the body. And excessive bicarb intake. So, nausea, vomiting, diarrhea. Anytime we get out of balance with our acid base, we can have some confusion, where you can see some tingling in the fingers and toes and some tremors. Hypokalemia. So if we've got too much base, we have hypo. If we have too little base, we have hyperkalemia. So the metabolic condition affects your potassium level. That's worth knowing because potassium affects your heart. So that's one of the reasons that potassium, anytime you see it in a question, is a big deal because it can lead to significant damage to your patient. When you're reading questions, you're always thinking, what's going to kill my patient first? How do you decide what's most important? What do I need to keep my patient from dying? Okay. Obviously, that's a little simplified, but it helps. Okay, what's most important, because prioritization is a hard part of getting some of these questions down. Good.
So it does cause diarrhea, and also kind of also tries to correct itself.
Yeah, exactly. That's the body compensating, trying to get rid of some of that base. Very good point. What he said is, hey, you just told me that vomiting gets rid of my acid and that leaves me with too much base, and that's why I'm in metabolic alkalosis. Then why would you tell me that diarrhea can be a sign of this? Well, because your body's always trying to get into balance, right? So it's getting rid of that base out of your butt. Good question. Here's our summary chart, just for fun and giggles. Another thing is that you can consume too much antacids. Antacids are bicarb. What's an antacid that you might take if you had an upset stomach? Tums. Someone has a bottle of Tums right here. If you take too many Tums, you can throw yourself into metabolic alkalosis. And I've seen it in the hospital. I've seen people admitted for metabolic alkalosis because they chew too many Tums.
Too much calcium, too little magnesium.
Too much bicarb in general. Blood, if they get like massive transfusions, sometimes significant blood transfusions can throw you into metabolic alkalosis as well. The memory trick, he talked about alkalosis, right? The vomiting. And some of the manifestations, those are our signs and symptoms. Tachycardia, your blood pressure may be fine or might be hypotensive depending on how severe it is. It's more likely to be normal if it's a mild case, right? Atrial tachycardia, the atrium's the top two chambers of the heart. And tachycardia, we said, is over what number? Over 100, right? And some ventricular issues. So you dysrhythmias, your heart rhythm is going to be messed up. Numbness, tingling. Tetany is sort of that muscle spasm Charlie horse. And respiratory depressed skeletal muscles results in ineffective breathing. So before we were breathing real fast, and now we're breathing not so much. We're depressed. Scenario, you ready? This is for next door. You guys ready? This is your scenario. Patient comes into the ED with fluid overload, and they're prescribed a diuretic called furosemide, and they're getting that by IV every 8 hours. They've been in the hospital 2 days. Now they're your patient on MedSurg. You go in and assess your patient, and you find the following. Your patient is tachycardic with a heart rate of 120. Your patient has muscle weakness, and you notice by looking at their eyes and nose that they've had a large amount of urine output. What caused this acid-base imbalance? Next door, it's on you.
They peed out all of the acid because of the furosemide.
That's exactly right. That's exactly right. So you have to watch for acid-base imbalance in our folks that get a diuretic because they can pee off their acid. Exactly. Good, good, good. These are smart. All right, we finished talking about the metabolic section, and now we're going to switch gears and go to the respiratory section, okay? So we can have respiratory acidosis or respiratory alkalosis. This is just a summary slide. It can be caused by respiratory, this is respiratory acidosis, right? So we've got too much acid. And that can be because of respiratory depression. Respiratory depression happens when our breathing is slow and low. Not very deep, and it's really slow. Let's think about, the video told us some too, so if you watched your pre-video, you've already got some ideas. But let's talk about what are some of the conditions or things that can happen to our patients that would cause them to have respiratory depression and be breathing low and slow. Alcohol. Opioids, exactly, especially like after surgery. So MedSurg, we take care of post-operative patients. So you really got to be watching for that. A pneumonia, right? COPD. Oh, you guys are good. Yes. Yes. And also OSA or obstructive sleep apnea, right? Can be an issue there. Good, good, good. I really love it. Hallmark of respiratory acidosis is you've got that decreased oxygenation in the blood, but you've got extra carbon dioxide in the blood, right? That's the acid that's causing the acidosis. Good. Here's our picture of respiratory acidosis. So you can see that I've added a few things to this slide, not just a picture. I've added a question. You know, it's all about respiratory, so we need to make sure that we know how to do a respiratory assessment. What kinds of things are we looking for to determine the respiratory status or condition of our patient? We want to look at the respiratory rate. That's the number of breaths they take in a minute. When you go in and you assess your patient, I like to put my hand on their chest while I'm talking to them, and I can either watch the clock on my arm or I can look at the clock on the wall and get an idea of how deep they're breathing and how often in a minute they're breathing. The rhythm is like fast or slow, and then the depth is shallow, is where you don't take very big or deep breaths, and then deep breaths are where they really dig in to breathe. Labored and unlabored would be if you can see them working to breathe, they're labored. We have accessory muscles here and in our chest. When we're engaging them, that's labored. They can be in a position called tripod where they're leaning forward. That opens up the chest and gives a bigger surface area for the lungs. That's why they're doing it, so they have better response and more oxygenation. So know your respiratory assessment. And then let's talk about what's going on. That hypoventilation, we've got that respiratory decline, right? Depression. So we're having hypoxia. We're not getting enough oxygen in our body, and we're not getting that CO2 out of the body. And because that CO2 is hanging out in there, we're becoming acidic. Shortness of breath, our blood pressure can fall, we have hyperkalemia, dysrhythmias because our potassium's all messed up. We get drowsy and disoriented, right? We can even die from this. If we're not breathing enough, we'll eventually get to where we just go to sleep and don't wake up. Fatigue and lethargy. And we talked about the causes, right? Anesthesia, drug overdose, COPD, pneumonia, atelectasis, bases of your lungs are collapsed, just from not taking deep breaths. Good, good, good. Respiratory acidosis has to do with hypoventilation. Severe acidosis makes your muscles weak. You just want to make sure I'm not missing anything. What's going to kill your patient the fastest? When you're doing your assessments, you want to make sure that you're assessing their respiratory status. ABCs, right? And remember your ADPI. What does ADPI stand for? Yeah, and the first one is assess. And that means that's what you do first. The nursing process is you assess your patient first, okay? And you're going to assess respiratory status. Because if they can't breathe, they don't have that long before they won't be alive anymore. And we know that they're at high risk for respiratory acidosis after surgery because of those sedating medications, the anesthesia and the pain medication. What can we do to counter the risk of respiratory acidosis in our post-op patients, in our pneumonia patients?
They breathe in it.
That is exactly right. That is exactly right. We can use an incentive spirometer post-op or with our patients who have pneumonia or are at risk for respiratory acidosis. That's where it makes you fill up your lungs. I tell them to pull the air in like you're sucking on a really thick malt. And that measures how much oxygen gets in the lungs. The bases of your lungs have these alveoli, and they get compressed when you don't take big breaths. When I was in nursing school, my kid was little, he's like 5, and I was talking to my husband about alveoli, and he says, our lungs have ravioli? No, the alveoli get compressed. And then symptom spirometer makes you take deep breaths and open up those at the bases of your lungs. And it's expected that they'll cough. That little friction can make them cough. That's not a bad thing. That's an expected finding, okay? Good. All right, let's go to respiratory alkalosis. What, next door, you're on. What's going on in the body when we are in respiratory alkalosis?
Not enough CO2.
We're blowing off too much CO2? Right, exactly. So one of the ways that we blow off too much CO2 is when we hyperventilate. This class, what does it mean to hyperventilate? Like a panic attack. You're in nursing school, you're probably familiar with that, right? You hyperventilate, anxiety, something's causing them to hyperventilate. They're breathing off that CO2 too fast and they're losing acid and causing an imbalance, right? The dog can't, yeah. So anxiety, improper vent setting. So if our patient has been intubated, they're not breathing on their own. Their acid-base balance is dependent on the settings of that ventilation, which means breathing in and breathing out. If we have the settings wrong, it can throw them into an imbalance. Fever, CNS lesion, salicylates, can't talk, can all cause excessive loss of CO2, that hyperventilation. That's what's actually blowing off the CO2 is the hyperventilation. And hyperventilation means breathing really fast, right? In and out fast. Yeah. Okay. Let's go to the next one. Did I already do this? Okay. Respiratory alkalosis. Let's look at our assessment. What's normal for the heart rate? Normals. This is what we would find in a perfectly normal patient. 60 to 80, right? That's normal. Tachycardia means a fast heart rate. What would that be? Above 100, exactly. Bradycardia means less than 60. Good, good. What's a normal respiratory rate? And I'll tell you that some places have different values. Yeah, so it can be anywhere from 12 to 16, but our older folks often breathe up to 20, you know. Yeah, so if they're breathing 36 times a minute, that's a big pressure, that's a big drain on the body. They're gonna get weak, and they don't always have enough buildup, enough compensation for it. So deep, rapid breathing, seizures, hypokalemia, confusion, nausea, vomiting. But the big thing here are the causes: hyperventilation, fear, anxiety. Hey, let's talk about PE. What's PE stand for?
Pulmonary embolism.
Yeah, pulmonary embolism. That's where we have a blood clot in our lung. About 30% of people, their first sign of a PE is sudden death. I work pulmonary MedSurg. We see PEs all the time. So I think sometimes I forget how serious a PE can be because I see it so much. But that can cause that sort of hyperventilation. Your anxiety goes up really high when you throw a PE. Okay. Let me see if I got some questions for you. You ready for another scenario? Let's apply some of this information. We'll go with this classroom on this scenario. Patient comes to the ED and complains of feeling like her heart is going to beat out of her chest. She's lightheaded. My assessment data includes the following. Her respiratory rate is 28. Her heart rate is 115. What acid-base imbalance is she at risk for? What's happening to her? She's hyperventilating. Yeah, probably from anxiety could be one of the causes, right? But she's hyperventilating, she's breathing too fast. That feeling that my heart's gonna beat out of my chest, right? This tachycardia, which is above the normal rate. Good, we went over the normals. Good. Good. Respiratory alkalosis, this is our summary page, our chart. Talks about causes, hyperventilation, fear, anxiety, sometimes some head trauma, excessive mechanical ventilation. We're not getting our oxygen. A high altitude sometimes can cause that, shock and asphyxiation. Good. A lot of the symptoms are the same, but the tachypnea, the fast breathing is a real big factor. All right, put on your nursing hats. We're going to apply some information. We're going to make use of this stuff. Can you hold on with me for just a little bit and then we'll have a break, okay? Can you guys hold on for just a little bit and we'll have a break?
Yep.
Okay, okay. We've talked about assessment in the first part of this PowerPoint. When we talk about the nursing process, ADPI, assessment's the first part, right? Just kidding. So let's talk about some of our assessment findings with acidosis, when we've got too much acid in the body. We know that risk factors for that can be a breathing problem or kidney failure, pancreatitis, fever, diarrhea. We either have something going on that makes our body retain too much acid or excrete too much base so that there's too much acid in the body. And that's what makes us acidotic. It can cause hyperkalemia. We'll see some changes in our heart rate, changes with our breathing, metabolic acidosis, or those Kussmaul respirations. What are those like? Fast and deep. Yep, respiratory acidosis is the opposite, right? Shallow and rapid. That's the panting dog. I really got excited with this slide. Skin changes, warm, dry, and pink. Acidotic or warm, dry, and pink. All right, metabolic acidosis can come about because of DKA, diarrhea, bicarb changes. You'll see these types of medications to help treat some of the respiratory acidosis. Anti-inflammatories, so like your IV steroids, bronchodilators to open up those airways, mucolytics like Mucinex to help thin secretions so they can expectorate, that means to cough up and out. Oxygen therapy, we want to use the least amount of oxygen necessary. Ventilation support if we have to. Monitor breathing, that respiratory assessment is critical. Evaluating, maintain adequate gas exchange. How do we know that what we're doing works? Sometimes they'll redo an ABG after an intervention. So let's say my patient was confused and her respiratory rate was 42, and I called the doctor and I said, hey, Mary Beth, in 326, she's in between 38 and 42 respirators a minute. She's really anxious and she's confused. She has sudden confusion that she didn't have on my last assessment. I think we need some ABGs to see how her body's using oxygen and the acid-base balance. We get the ABGs, that's usually a stat for our floor. We get the ABGs and it shows that she does need some intervention. So we put her on a BiPAP. So it's like a big mask. The CPAP will have a mask too. But the BiPAP, the difference between CPAP and BiPAP, CPAP is continuous, blows all the time. BiPAP goes in and out, in and out. So it's kind of pulsating so that it helps her breathe in and out.
Like a nose.
It's got a tube. It's got a tube, and it helps. It's a step before intubation. She stays on that for 4 hours. I take her off, put her back on her nasal cannula to have some dinner, because you can't eat while you're on it, right? You can't have anything to drink hardly either, because you're at aspiration risk. If I give you something to eat or drink, and then while you're on this big mass that blows this air, oxygenated air in your body, and you cough up some fluid, it could go right into your lungs instead of back to your stomach. And then you got pneumonia. That's a whole nother breathing problem. So you have to be careful with that. So she comes off, she's not confused anymore. Her respirations are down to about 22. So we get a repeat ABG to evaluate if it's effective, to see if her body has compensated or balanced out. Okay. Good. Let's go ahead and take a little break. We're going to take a 10-minute break and then come back and finish up hard. There's just a couple more slides. Get in, get a couple steps in. Let's see, it is 33. Come back at 43. Okay, get a few steps, breathe, have a drink of water, and let's finish up strong.
Can you go to lunch at 11?
Yeah.
11.
Yeah, it was freaking ridiculous. Yeah, you're about 40 minutes.
Yeah.